Hello, dear colleagues. I would like to thank the organizers for giving me the opportunity to present the Bulgarian data on GNE myopathy on this very interesting conference. So as we have heard, this disorder has a pan-ethnic distribution with an estimated worldwide prevalence of 1 to 9 per million. And there are different founder mutations that have been found worldwide, actually. One of them is among the Gypsy population, and this is the predominant mutation that we've seen in our group. Actually, you know that Roma Gypsy are young, isolated Asian ancestry with strong founder effects. And apart from GNE myopathy, we have other autosomal recessive mutations for congenital myasthenic syndromes, for limb-girdle muscle dystrophies that are specific for this population, and they're very frequent in Bulgaria. So in our cohort, we have 54 patients with GNE myopathy. And you can see that the majority of them, they're homozygous for this typical mutation. We have only 2 compound heterozygous carrying different mutations. And during a screening performed with Professor Luba Koligieva of 660 ethnically matched controls, we have detected 11 heterozygous carriers, which means an overall carrier rate in the Gypsy population of 1.67%, and all they belong to Roma Gypsy groups from the Balkan migrational category. So if we look specifically in these Balkan groups, we can have an estimated carrier rate of 2.84%. So in this specific cohort that we see in Bulgaria, the predicted incidence will be much higher, around 1 per 5,000 birth. This is why we have in our country of 6.5 million, we have so many patients with the same mutation. We know that this specific mutation was found in India, mainly in the region of Rajasthan, in the northwest part, from where this exodus of Gypsy Roma started. So this finding points to the ancient origin of this mutation, preceding the exodus of the proto-Gypsies from India. In terms of clinical features, we have broad age at onset. As you can see, the majority of the cases, around 2/3, actually have an onset in the 3rd decade, while 13% they have an onset, a later onset after the age of 30, and 13% below the age of 20. And of course, the initial manifestation are the same as in the original report: distal muscle weakness with initial more prominent involvement of the tibial anterior muscle, extensor digitorum brevis, and abductor hallucis. Actually, in the advanced stages in our group, we did not observe substantial difference in the weakness of the anterior posterior distal muscles in the lower limbs. Muscle strength was preserved in the quadriceps femoral muscle. Actually, in 18 out of 54, it was fully preserved 2 to 10 years after the clinical onset of distal weakness, while in the rest, we have impairment on the MRC scale ranging between 3 to 4 per 5 in these patients. So the distal weakness in the hands occurred around 5 to 11 years after the clinical onset, with the extensor pollicis longus and brevis, interosseo dorsalis, pronator, flexor carpi radialis, and biceps brachii being the most involved and initially involved. Actually, in very few patients, in 3 patients, we have initial weakness in the distal muscles of the upper limbs. Actually, These patients, they had a more benign course, being still ambulant between 12 and 20 years after the clinical onset. In our group, the proximal muscles of the upper limbs became involved 4 to 15 years after the initial distal involvement, and scoliosis was not present. Next flexors were severely affected in the bedridden patients. We had 10 bedridden, and we can tell that during a follow-up of 18 years, 34 patients lost ambulation, and this was after a period of around 10 years, but it was ranging between 3 and 20 years. We performed some statistical analysis, and we do not find any correlation between the age at onset and years of preserved ambulation, nor between the disease duration and current functional status. So we can tell that there was no evidence for more rapid disease progression in those where the disease started in an earlier age. The cardiac involvement actually was a little bit contradictory because being an adult onset myopathy, of course, some of our patients had comorbidities such as arterial hypertension and diabetes. What we found from the EEG, 3 with repolarization abnormalities in the inferolateral leads. In one patient with arterial hypertension and left ventricular hypertrophy, ventricular premature beats were registered. On echo, 3 of the patients had a borderline ejection fraction, and impaired relaxation was found in 8 patients, including the patient with reduced ejection fractions. 6 patients had history of arterial hypertension and 1 with diabetes. So we've heard from the previous presentation that actually respiratory function declines with the progression. In our group, the forced vital capacity ranged between 60 and 75%. It was measured in 7 out of 27 individuals, 3 of whom were bedridden. So we can tell that it was relatively preserved. So in conclusion, for our group, we have a typical founder homozygous mutation causing the vast majority of the cases with GNE myopathy in Bulgaria among the Gypsy population. The clinical course and severity of the disease, however, show inter and interfamilial variation despite the mutation homogeneity. So we can speculate that there are possible contribution of genetic modifiers, which of course we'll have to prove in the near future. And what we have as a routine for our patient is to follow them up every year, assessing their motor, respiratory, and cardiac function by the multidisciplinary team in our group. Thank you for your attention.